Good morning, everybody. Thanks, Amish. Thanks, Dr. Purvish. It's lovely to be in front of human beings who are actually sitting there. Right? And I'm not going to ask you today, am I audible? Am I visible? All these things are hopefully gone. I wouldn't say forever, for at least for a reasonable period of time, or hopefully forever. Amish, by asking Dr. Sudeep to talk here today, you made sure that I will not talk about hazard ratio for the rest of my life. Right? That is for sure. I will not. Okay. Okay, Dr. Basade is missing. That's all right. That was really a scholarly talk on hazard ratio and the many other important. Yeah. Audio nahi hai. I think they're able to hear, isn't it? Yeah, I said I'm not going to ask you that question. He made sure I asked you that question. All right, there we are. So I don't, is there a pointer here? So does that look like Amish? The one on the left standing on top of Dr. Purvish's hand?
Yes.
Yeah? Yes. Certainly not Amish, at least from body surface area standpoint, if not anything else. All right, great. So we will discuss 4 studies today. I think the pointer, yeah, it's working. So we'll discuss monarchE, the butterfly, we'll discuss destiny, we'll discuss Olympia, and then we will discuss her climb, right? So those are these. So Amish showed you these approvals. Amish, it's 11:20, so I will stop at 12. We'll save some time. Okay, so 2 approvals that are around. So let's start with this case that not exactly is what Amish told you, but something very similar to that. So here is a 44-year-old premenopausal lady, ductal carcinoma, invasive grade 3, T2N1. That's let's say a 5 centimeter tumor, ER/PR strongly positive, HER2 is negative, the Ki67 is 30%. I put up a few options there, but let me start with Chetan. Chetan, what is the likelihood that this lady will relapse in the next 5 years? I think we should know that first for us to be able to meaningfully discuss the benefits of our treatment, isn't it? So what do you think is the likelihood that this lady will relapse in the next 5 years, 10 years, and so on?
About 10 to 15%, 10 to 12%.
10 to 15%. Amol? 10 to 15%. So are you looking at a composite risk? Now you're not only looking at N1, let's say that's 3 lymph nodes. There's a grade 3 and then there is a Ki67 that is 30%. So when all of these are put together, does that risk go up, or would you just consider the lymph nodal status to say that this is likely to be the risk?
Because there is a Ki67 37% and
Okay.
it's shown to be a prognostic marker.
Right.
So yes, the lady with
So 3 nodes plus a Ki67 that's high, that's grade 3, is likely to have a higher risk. Absolutely right. So here is the EBCT-CG analysis that's showing you that if somebody has got an N2 node, the 5-year likelihood of getting the disease back is 20%. 10%, absolutely right, both of you. But there's also data to clearly show that if you've got 1 to 3 lymph nodes and your grade is also high, your risk of recurrence is very similar to what somebody with an N2 will be. That's not shown on this, but there is data to say that. Dr. Ritu, what would be your choice of treatment for this lady? Cost is not an issue. Abemaciclib is available at 10 rupees a tablet.
You made mine.
Give tamoxifen a more. We won't miss tamoxifen for sure.
You made mine and the patient's life easy.
Pardon me.
You made mine and my patient's life easy by saying I'm
Excellent. So
yours is available at 10 rupees. So given the data as of today, I would prefer the option 4.
So you would do option 4. Excellent, Prabhat. What would you do?
Opt for no abemaciclib at this point.
You would not opt for abemaciclib. Excellent. Vashist?
So currently I profess option 2 as chemoradiation OFS.
Okay, chemoradiation OFS. So no abemaciclib. Chetan and then Amol?
Right now, out of compulsion, till it becomes 10 rupees, yes, it is going to be chemoradiation.
Okay, so if cost is not an issue, abemaciclib is there on your list. Amol?
option 2.
Option 2. So we've got 1, 2, 3, no abemaciclib. 2 of you said abemaciclib. Excellent, very good. So we will get on with the study. So a couple of important things to note, that this is a trial which had only patients with node positive disease. Okay, so that's very important to keep in mind. Even if you had a T4B, you were not qualified to get into the study. Please remember that. Though we would say the risk of recurrence would be quite high for somebody with T4B, all patients went in with nodes that were positive. This was something that you actually asked Dr. Sudeep. I put this on this slide. The assumed primary outcome in the control arm, you were just asking him, how do they really decide? So this is roughly one of the ways of deciding. So the assumed primary outcome in the control arm was a 5-year invasive disease-free survival of 82%. That means the expected was at the end of 5 years, 82 points. That means 17.5% was the likelihood that they would get their disease back. And that's exactly why they took all patients who had a higher grade, at least N1, because that, based on some available data, told us that the likelihood of getting the disease back in the next 5 years was roughly around 20%. So that's how they ended up with that number, or that kind of risk group that was chosen as the standard, or as patients who would get into the study. And also the question that you asked, this is what they expected based on the statistics, an assumed effect size of 0.73. So that's the statistics that they had planned for. The primary objective is invasive disease-free survival. So there we start. Chetan, you're happy with event-free survival, isn't it? You're happy with Prabhas, or you want Rana?
I'm happy with event-free survival.
You're happy with event-free survival. Prabhat, why is it that you would not be happy with event-free survival as a primary endpoint? Because let me tell you that we always analyze the study for its primary endpoint, right? So even if the study doesn't show you an overall survival 25 years from now, that should not be taken into account to make decisions, at least based on the statistics, because it's not powered for that. And then they will say this long follow-up that's necessary, positive disease and all that we typically hear. So keeping that in mind, why is it that it's not an accepted endpoint for you?
Sir, because it is a static drug, most probably abemaciclib will just suppress the cell in the G1S.
Is that not good enough for you, is my question?
No, sir.
No. So you will always ask for overall survival. Do you use aromatase inhibitors in your patient over tamoxifen?
Yes, sir.
Is there an overall survival that's clearly proven?
No, sir.
Why are you using it?
Rarely
Because it's
I use
cheaper, right? Okay, good. No, that's important. That's important. That's practical. That's an important issue from a practical standpoint. There are situations where we may want to accept an endpoint. There are situations where we may not want, and the reasons might not necessarily be to do with a statistical endpoint. It might be to do with cost. Amol, yeah, you're ready to fire.
So in this particular group of population of ARPR positive, HER2 negative, IDFS till date has not shown to be correlated with the OS. It has, in the meta-analysis, it has shown in tendency to correlate with OS in triple negative and HER2 positive.
Triple negative and
ARPR
HER2
positive,
positive.
HER2 negative, which is the current patient, IDFS has not in meta-analysis shown a correlation with OS till date.
I am not clearly aware of that, Amol, but my understanding is that it's accepted by the FDA as a surrogate endpoint in breast, colon, renal, and all these now. And I'm sure they've had their reasons for doing that. Anyway, your point is well taken. Vashisht, you also said that you're not happy to incorporate abemaciclib in your patient's management. Any specific reason for that? Is that cost, or you don't accept EFS as an important endpoint?
I accept IDFS as a current surrogate. I am not excited about the quantum of the IDFS.
You're not happy with the quantum of benefit. So then hold the mic on, Vashisht. What quantum of benefit would make you use this drug? So I'm showing you the IDFS for the intent to treat. That's the blue highlighted one. So you've got a hazard ratio of 0.69. That's a 31% risk reduction. A delta of 4.5. Okay, so that's in the intent to treat. And if you look at the FDA approval, it's for patients who have a high Ki67, and that's on the right side table. You've got a hazard ratio or the risk reduction that's about 37%, which is better than for the intent to treat, and a 7.1% benefit, which is much higher than many of the other interventions that we routinely accept to do in day-to-day practice. So I just want to know, it's not wrong to say I'm not happy with the benefit. I'm just wanting to understand from you, what's the rough number that will make you use this intervention? I'm not saying you should. Please don't think I'm coercing you to use it.
Lovely. Sir, I think conceptually risk reduction is something that Sudeep sir beautifully took us through of the relativeness of that number. So I'm not very excited about the 37%
So
relative
you
risk
think
reduction.
you want a better number.
I
So
would
what
have
would,
I would have loved an absolute benefit at 3 years of more than 10% for me to be practice changing. Why is this number 10%? Honestly, I don't have a crystal ball as to why I believe.
okay,
But yes,
fine, that's
that
all
would
right.
be for me a practice
Yeah,
changing number.
Amish wants to ask you a question.
Yeah. So, why, matlab, I can't understand 7% is not good enough and 10% is good enough.
I gave a
Amish, we'll leave it.
strings attached as to I don't
That's
have a
all right.
rationality.
Everybody
behind
has
it.
their own impressions of what the
Can I
benefit should be.
comment on
That's
this?
all right. Yeah,
Can I?
Amol, please go ahead. Amol.
It is not the question of whether the 7% benefit is significant or not. The question is how that 7% has been achieved. If you
Okay.
see that this particular trial, the FDA has given approval for Ki-67 more than 20% only.
Okay.
Entire trial has only 44% of patients who are Ki-67 more than 20%.
Who told you that, Amol?
So that is
No, that
sir.
is cohort 2, which has only patients who are high Ki-67. In the intent to treat, nearly 50% have a high.
No, sir. What I have done is that I had analyzed this. Cohort 2
Amol,
has only 10%.
I did not counter you on your previous point because I was not sure. I am 300% sure on this.
The absolute number of patients in cohort 1, cohort 2. Who
Amish,
had
can you open and then
Ki-67
clarify? I am sure about what I am saying. It's not, nobody will come to a conclusion based on less than 10% Amol. I think we should just,
No, the total number of patients in the trial which had Ki-67
Amol, you are
more
wrong.
than 44.
Amol, you are absolutely
more
wrong.
than 20% is only 44%.
Amol, all comers.
All comers, it is more than that.
Okay.
And we will show you. Just let's go.
So let's read that again, Amol. Okay. So cohort 1 has all patients irrespective of Ki-67. Cohort 2 was based on a regulatory requirement because they wanted to go and see what's actually happening to those patients. It was mandated by the regulator to add some patients who had only Ki-67, but that did not conform to the anatomical risk that was used in cohort 1 to choose their patients. So nearly 50% of patients, not exactly 50, it was 47 or something like that. That was the number, 47% of 5,600 patients. I think that's reasonably good numbers to come to any conclusion. And the statistics was already built in to look at, it was adequately powered to look at an IDFS in that group only. So you need to go back and do your homework, Amol. I'm sorry for that. You're not drawing. We will.
I was saying it is 44% in the entire population.
That's not bad, isn't it? 5,600.
He said 44%.
Yeah,
I thought you said 44 patients.
no, 44%.
That's nearly half, isn't it? That's what we would do in practice. So if it's powered to look at that, and if it ended up being positive, what's our problem? Whether the magnitude is adequate or not is Vashish's point. That's a different issue altogether. But yes or no, is there a benefit or not? The benefit is there, and that's the benefit I've shown.
My second point, sir, if you allow,
Please.
is that Ki-67 is still now shown to be a prognostic marker.
Correct.
It is not till now shown to be predictive marker.
I agree.
There is no phase 2 data to show that Ki-67 is a predictive for CDK inhibitors. In fact, in a palbociclib trial, which was done in adjuvant, which is Penelope B and this Palas trial. In Penelope B, they have a risk stratification based upon Ki-67, 15% cutoff, and they have shown that it is not making any difference. That means both Ki-67 above 15, less 15, the results were
So,
same.
you're right.
In
So
Palas also, there was no
So the
difference.
trial is not telling you that Ki-67 is a prognostic marker. It's not a predictive, it's a predictive marker.
But FDA is saying that based upon
No,
the
no, I think
approval,
you're-
that if the Ki-67 above 20, you can use abemaciclib.
Amol,
That means
your interpretation of the FDA approval is not appropriate, Amol. It's not that. So they are saying that there is more benefit there. So at this point in time, we will approve it for that cohort of patients. Maybe wait for a little longer. If the benefit gets better in the lower Ki-67 also, then you would probably use it in that. The approval might actually expand. In fact, if you look at what the ASCO statement is, and if you look at the EMA approval for the drug, it is irrespective of the Ki-67.
my
Okay?
last point, sir.
Yes, please.
The OS is detrimental in those with
It's already there. The numbers are there. Numbers are there. I put it 1.091.
Yeah.
So you're saying it's a 0.91091 detriment. You're worried about that? So Amol, I think we should not look at everything as a, as a backdoor entry to getting something done, Amol. I think we should look at it. So let's look at your point of, the high Ki-67. I entirely agree that there is no space between those two curves at this point in time. The overall survival is not obvious there. I don't know, based on, you just keep drawing that line, horizontally, there's unlikely that you will see an overall survival benefit also. I entirely agree with that, right? But at this point in time, can we clearly say that there is a detriment? We clearly can't say. We clearly can't say, right? Because the study is not powered to look at that particular issue, right? Yes, Ritu?
No, I'll just, why did I choose the option 4 was, because the primary endpoint of the study was IDFS.
Right.
She's a young patient with an aggressive disease.
Right. And you want to do everything possible.
And you are giving me the amoeba for 10 rupees. So I would definitely, and I think most of us in the audience, Amol, I don't know, most of us would want to give this patient the best chance, though as what I understood that OS hazard ratio was dynamic, but Sudeep sir clarified. So we will need longer studies to see the overall survival difference. But at this stage, somebody comes to me with and you're giving me 10 rupees, I will go for the fourth option.
Right.
I will keep the 10 rupees abemaciclib reserved for relapse.
No problem, Amol. I'm not against keeping the abemaciclib for you. Have your opinion. Chetan.
What I was one of the investigators for monarchE.
Excellent.
Ki67 is an extremely variable mark.
Absolutely.
You have Ki67 from different labs, you'll get ranges from 10, 20, 30, 40, 50. So alone Ki67, notwithstanding other high-risk features, like I had this lady, she's 44, imagine a lady T2N2, 4.5 centimeter tumor, 8 nodes positive, ERPR positive, HER2 negative. What do? She is high risk.
Absolutely.
8 nodes positive, N2, her chance of relapse is about 20%.
So I've come to that
is
point.
Going to reduce by even 4.5%. I think that's improvement. Absolutely. And if it comes at 10 rupees, oh well.
So I think if I can quickly summarize. So I put 3 clinical situations here where patients would have a significantly high risk, okay, significantly high risk of relapse, but they will not qualify for the monarchE because the patients who were taken into the study did not have these characteristics. All of number 1 on the left, Amol, I don't want to talk about, I don't want you to say that this is not a good test or a bad test. The reason for putting it up there was not that. It is to show you that a patient with node negative disease had a 38% risk of recurrence, right? So not qualifying for abemaciclib as per monarchE, but all of us would think about it. One on the top 55-year-old oncotype DX was done because it is N1 and she's postmenopausal. Risk score is 18, which means she doesn't even need chemotherapy, right? But she would actually qualify based on monarchE. To do or not to do, I don't know. 4.5% of patients in the monarchE actually did not take chemotherapy, but they still went on to the study. Point number 3, although we may say the value of a PCR in patients with ER positive disease is not very strong, here is a patient who was weakly ER/PR positive. It's qualitative interpretation at the end of the day. So she had a YPT0N0 after neoadjuvant chemo. We know that this lady is likely to have very good outcome, but she qualifies for monarchE, right? So I think, as Dr. Sudeep rightly pointed out, these numbers are for us to understand what not in terms of some benefit or detriment. But what benefit will push you to use it depends upon how desperate you are, isn't it? If it's a 32-year-old lady who comes with the same features that I showed, you would want to go blazing all guns for that lady rather than say, you come back with disease 5 years later, then I will give you abemaciclib. I won't be able to cure you. For the rest of your life, you will be in and out of hospital. You will probably need chemo, this, that, and everything. I think we just need to, I'm not against pushing abemaciclib. Let me make that very clear. I'm just trying to say that we need to ultimately ask our patients, as was again rightly pointed out by somebody during Dr. Sudeep's discussion, explain to them as much as we can. It's not easy to explain DFS, OS, and all those things to our patients, but I think it's very, very relevant for some of our patients, less relevant for some of our patients, and probably irrelevant for some patients and doctors also. But that's a different issue altogether. We cannot generalize and go ahead with that. So it is, yeah, Amish, quickly, and then we move on.
Just in yes or no, all 3 patients, what would you do about abemaciclib?
I've discussed with all of these patients. Yes, I've discussed and 2 of them are taking it. Okay. In fact, I've discussed in some forum where all the so-called experts, nobody gave me a good answer because everybody wants to stick to the label. That's how, people in the West practice medicine more often. I'm not blaming anybody like that. They will give you a diplomatic answer the moment you put a question like this and then say this is not the label for approval. So I would do this, I would do that. But I spoke to them and I did it. Okay, and I don't have any. I'm not.
Sir, a quick point.
Yeah, quick point.
So, sir, tomorrow if a patient asks me that if I prescribe this drug, am I less likely to relapse?
The answer
Should
is
my answer be yes?
okay. So
or
that's
no? Because
shall I
that's
give you a
most
statistical
likely-
answer to that or a general answer to
A
that?
patient wants to know, sir. Patient does not understand statistics.
We will say your likelihood of relapsing is going to be lesser compared to somebody who is not taking this. That's what you would say, right? By that 32% or 35% or whatever it is. Now, next question comes is how wide is the confidence interval? Right? Your hazard ratios can fall anywhere in that confidence interval for 95% of your patients. So your patient could have a benefit, but as was again pointed out, it could be on the left extreme of that confidence interval. Another patient could have a benefit or a hazard ratio that is right extreme of the confidence interval. Right extreme is 0.97 for a patient whose Ki67 is low, and that's one of the reasons why the FDA probably didn't go and approve. So there's a 3% relative risk reduction for some patients, while there might be a 60% relative risk reduction for another patient. So again, I want to, quote Dr. Sudeep's golden words. These are for interpretation of yes, no answers, some idea of what your patient is likely to have, but you can never say what that individual patient will have in terms of benefit. He spoke about informative censoring. That's a lovely, interesting topic by itself. Let's go on. We've got only 29 minutes to go.
I would want one more question to be answered for my patient.
Okay.
So I have told this patient that you're more likely to benefit if you take this drug. If the second question that the patient answers in the same context is that, are you potentially harming me by giving me this drug at this point of time? Should my answer again be no?
In terms of an adverse event, yes. So you should look at what the adverse event profile of this, how many patients discontinued, about 12% if I'm not mistaken. No, you're talking about Palace. Okay, you're talking, yeah. Those reductions are going to be required. It's like all of us use Sutent, isn't it? Isn't that hell? We continue to use it?
Not in the adjuvant
Everolimus,
setting yet.
alpelisib.
So not in the adjuvant setting yet.
Alpelisib. Let's get on.
Sir,
28 minutes. Amol, no. We'll hold on. Okay, next. Okay, same lady has got a BRCA1 pathogenic. Same lady. Olaparib, no Olaparib. Amol.
If I'm using platinum drugs in adjuvant chemo, I will not use Olaparib.
Okay, so you have not understood or refused to believe what Dr. Sudeep just said. So if you're taking platinum drugs, where did that conclusion come from? That's the forest plot I'm showing you. Please interpret this forest plot for me and tell me why is it that you won't use a platinum drug. So 23% of patients took platinum, and I understand that your reason for not using a platinum is because the point estimate is to the right? It's crossing 1.
Yes.
So he just now told you that you should look for the p-value for interaction or heterogeneity, and clearly you see that the p-value is not significant. And I don't think we should be carried away by what happens to 20% of patients in a study that had a couple of thousands of patients, right? The second, Amol, is even if you tend to believe that, there should be a good biological reason, again, as he rightly pointed out, to say or explain this trend in the opposite direction. Do you have a good biological reason to say that a PARP inhibitor won't work after a platinum?
In the brightness trial, it was shown that those who had taken platinum, the addition of PARP has not made much of a difference.
So the primary endpoint of that was different, Amol. The primary endpoint was looking at pathological complete responses. Let's not get into that controversy now. We're not getting into whether PCR is a good surrogate or not. That's a full day program. Amish, we can have oncology beyond the obvious PCR in various anatomical subsites. My 50th? Okay, in HICC Hyderabad. So let it be so. So there are people who think that there might be some PARP reversal for patients who took platinum. Again, that probably is not right, because the classical example is ovarian cancer. You always use a PARP inhibitor as maintenance post-platinum. So it's unlikely. So the point I'm trying to make is we should not get carried away by, these directions that these forest plots show, unless there is a good biological reason to support that, or if the interaction P is significant. These are the two situations where we would do that. That comes to the question of, well, let's say Chetan, ER positive patients were later included in the study. Only 18% were ER positive. So do you believe that this intervention does not work in patients with ER positive disease?
I think it will work in ER positive as well.
You think it will work in ER positive?
Senthil,
also? Yeah.
Senthil.
Yeah, Amish.
In this forest plot, in HR positive patients, there were two categories, I think so. One was neoadjuvant chemotherapy and one was adjuvant chemotherapy. In NACT, in fact, the hazard ratio was towards 1.
So I think that will be even torturing the data further, isn't it? You know, you're working on 18%. Amol is not prepared to, you know, even accept that, and you're saying divide that into two halves, neoadjuvant and adjuvant.
Amol's oncology is different.
No, no, with Amol.
I am from the lower and middle class income countries, so I'm thinking from that point. I'm the LMIC oncologist.
Amol, no, we respect your views. I mean, there's nothing to say that what you're saying is wrong. You have your opinion, at least on my panel, you can say whatever you want to say, right? That's all right. I entirely, no, there are a lot of at least most of the points you make are very, very valid, Amol, right? So please go ahead and make your point as and when you think it is. So we think that there is a benefit in patients with ER positive also. So the case that we put up and the case that Amish actually wanted to do this, to do that, or to do neither or both, that's the question. Prabhat, I want you to take that. So would you use abemaciclib and olaparib in this patient, or you would use one of them only based on whatever you think is appropriate?
If I have an option, BRCA positive who is HER2, even hormone positive, I would choose olaparib.
You would choose olaparib. You rightly said you are not happy with abemaciclib and its benefit. Amol?
Yeah. If there is a BRCA positive patient, I will prefer Olaparib if I have to use either of the two.
So you're happy to do it in that 18%?
If the patient is BRCA positive, and I have to use
based
either
on
of
the forest plot, there is no benefit. That's the
what I'm
reason
saying.
why.
But then actually there is some biological sense of using Olaparib in BRCA
There is
positive,
some biological
so hence
sense.
I will use that.
Excellent. So there is some biological sense, so we will use it. Excellent, no problem. Ritu, both? Same 44-year-old, desperate.
If she's BRCA1, I would like to give
Okay,
Olaparib.
both? Excellent, both. Yeah.
No.
Oh, only olaparib? Okay. Any specific reason you don't want to use abemaciclib now, Ritu? You can reduce the risks with abemaciclib. You can improve the survival with olaparib. Doesn't that look more attractive?
It looks attractive, but I'm not too convinced about both the drugs together.
Oh, you're not convinced about using
And
both
the
of them
cost
together.
also would be a major
Cost
issue.
would
for
be
me.
an issue. 20 rupees for abemaciclib, 30 rupees for olaparib.
And the toxicities. I would be concerned about toxicities also.
Okay, you would be
because
concerned
we do
about
not have data.
toxicity. Ullas, what about you? You want it for 5 rupees, eh? 15 rupees. I know, you will come to bargain. Chetan,
Where did the combination
Frankly,
come from?
where did the combination come from?
Yeah,
Good
I know.
question. It will never come. So we need to use our judgment to decide what we want to do.
As
We
of
can't
now,
ask
I
for a
don't
trial
think
for everything.
there is any scientific data to say that combination should be used.
I'm
I'll
not saying
prefer
use
one
it.
of the two.
I'm not saying use it. You're all guys are, you know, looking at me like as if I wanted you to use it.
Senthil.
I'll use one of the two and I'll probably use Olaparib.
Okay. Overall survival benefit, biologically driven olaparib.
Senthil, if
be
you want
mind-boggling to juggle
answer,
them.
we can sequence it.
Excellent. If you want
We
to
can
decide to sequence it, you can
because we
sequence
have Amibaka data for 2 years and then we have a BRCA1. So maybe you can take the lead and ask us to sequence it.
Okay.
Yeah, but then how would you sequence it?
How would you
Because
sequence it?
The funny part is, for abemaciclib, the cutoff was 16 months. So beyond 16 months, there is no data. It has not been tried. In fact, I had one of my patients ask me, she was screen failed because she had some concurrent bad
So
infection.
there was, you could
3 years
actually,
down the line, I don't have an answer.
so you could actually, I mean, based on I know very few patients would have fitted into that. You could actually start your drug 16 months from the time of surgery also. So yeah, Amish, and then quickly. I will.
Everybody said Olaparib. Of course, I'm not the panelist, but I would say is that Olympia, where 82% of the patients were TNBC, there is forest plot chart up and down here and there. monarchE, 100% patients HR positive. The eligibility criteria of Olympia is so confusing, even for HR positive patients also.
Even for you.
Even for me.
So then it has to be confusing for everybody.
You know, in monarchE, at least in one subgroup of Ki67 high, they have shown a very good IDFS of 7%.
So you're saying use both?
I would use abemaciclib right now in this particular patient, explaining to patient that I would wait for Olympia OS advantage. They have not dissected into HR positive and HR negative, to the best of my knowledge.
Because again, it's not a trial that is powered.
Olympia has been driven by TNBC and not as HR positive.
So Amol, he's saying that 18% you decided to use
I
it
fully
based
agree
on
with
that.
him on this
You agreed.
particular
So
point.
we
But
start with
my
tamoxifen.
question was that you have shown in the previous slide that who
Interaction
is the
G is not
winner,
significant.
who is the winner amongst the three? what can be the reason why the palbociclib has failed in adjuvant trial and abemaciclib has happened to show some benefit in adjuvant trial? What according to you can be the reason?
I think the simple answer is nobody clearly knows. Nobody clearly knows. Though abemaciclib seems to be different in terms of its, differential activity between CD4, CD6, CD9, CDK9, not CD9.
But in metastatic setting, it has not made any difference. Both have shown OS benefit.
I'm coming to that. Amol has become an examiner today. Right? So, when you come to the metastatic setting again, Amol, so there is some difference. We don't know what it is. I think let's be humble to admit that. That's number one. Number two is, if you look at the dosing, right? I'm just trying to say what is in the literature as to the possible reasons. We don't know the exact reason. Let's accept that. The continuous dosing seems to make some difference again. And the differential activity and the additional cyclin-dependent kinases that it might inhibit may be making a difference. And the reason why I'm saying this is that I at least partly accept this is because if you look at both the metastatic and in the early setting monarchE, it seems to be effective in a set of patients who are primarily resistant. Where again in the metastatic setting, palbociclib failed. Let's not cross-compare studies. We know that the inclusion criteria for these studies were different. But if you just, on the face of it, look at the results of these studies, definitely there's something to abemaciclib which is not there with palbo and ribo. What is that something is something that we are not very clear about at this point in time. Okay? So, yes, sir, yes.
In the first line metastatic, only pembro worked. Nivolumab didn't work.
So there's some.
These drugs are different, and something which is there in second line will not be always in the first line. I'll show you in my design about adjuvant pembro not working in PD-L1 more than 50%.
Correct. So there are things that we know. There are many things that we don't know, and let's accept that we don't know many things. So you all have your points. All of us attempted to use Olaparib, even though only 18% were there because there's an overall survival benefit that's clearly shown now. But if you decide to use both, the thought is that you start with Olaparib, you complete 1 year of Olaparib, and then you could use abemaciclib. That's one way of doing it, but I don't think anybody has the right answer to that question. Amol, Olympia versus Capecitabine, both are same cost. Don't say I will use both.
No, I will still prefer to use Capecitabine because it's a longer available drug and we are more comfortable using it rather than Olaparib.
So it's your comfort that is so. You're not.
The cost is same for both.
Cost is same, 5 rupees for both. Yeah. Right?
Go for Capecitabine.
So now you're moving away from precision medicine to imprecise medicine.
No, because in a BRCA, if you say
BRCA positive, I'm talking about a BRCA positive.
So in a BRCA positive, if I have an option to use both, my personal preference would be Capecitabine because I used it for a longer duration.
So it is purely based on your comfort.
Yeah.
Nothing beyond that. Ritu, which one would you choose, Olaparib or Capecitabine?
Olaparib. Even though I have no much, as he said, experience, I would use and get experienced.
And you will use it and get experience. That's a nice way of saying it. Very good, Prabhat.
Capecitabine, because I have long-term data, 15 years data, that it is not, may not cause potential long-term side effect, which is possibility with the Olaparib.
So the Olympia did show less than 0.5% MDS and leukemia. Your point is well taken, but just to reassure you. So correct. So I think we need to look a little beyond that, Amol. So you have to look at how much of chemotherapy was used. What was the clinical setting in it? How heavily were these patients pre-treated? And then say that we all accept that there's a slightly higher incidence. But when you use it early enough, it looks like, at least based on the follow-up that we have as of now, the incidence is not that very high. Now we have, long-term follow-up on the first line, the solo one, right? So it is a concern. Nobody is saying no, but that need not necessarily be a reason to be Capecitabine, hand-foot syndrome, your DPD polymorph. I just have a patient whom I put on Capecitabine, just 2 days of Capecitabine. She's in with me with mucositis, diarrhea, 0 blood counts, right? So let's not go away with the impression that Capecitabine is an easy drug to use at 2 grams per meter square twice. Wow. So, sir.
When we talking about this
Abema. Interaction.
Real life situation, who fits all the criteria for your monarchE, but are head to cost.
Good question. So, out of the label.
Dogma that I
I think that has to be an individual patient discussion, sir. I don't think, as I said, nobody is going to give us, do this. If we feel that the risk is high enough and if we believe that this intervention will bring down that risk, I think it makes sense to talk to our patients about it rather than, stick to labels, is my personal opinion, because I have more patients, not that I have tons of patients on abemaciclib, whatever handful I have, there are more patients who don't fit the label than who fit the label. So that's the point I'm trying to make. I mean, I may be found fault for doing that, but I'm fine with that. So, Dr.
Senthil, any data, high, strong ERPR positive patients with the BRCA positivity, how often do you find them?
The likelihood of having BRCA in ER positive, is that what?
BRCA in strong ER positivity. Generally, we say
I don't know
that,
whether there's any data on strong ER positive versus not, but we know that in ER positive, it's 5% or less.
5%.
Yes, correct. Okay, so I'm not going to make any conclusions here. Dr. Sudeep, who is much better, wiser than me, will make those conclusions. I think he looks, he may want to run away now if given the option. But, unfortunately or fortunately, you have the privilege and honor to do the conclusions. I'm not going to do it because I'm just supposed to, put forth the views as has been suggested by Amish. Okay, so we are done with Olympia and Abema, but I'm glad that there was so much of controversy and, discussion. It's always nice. Okay, we'll move on, 1448 to go. We will quickly run through the metastatic setting. Quickly, let's ask the audience, what is your second line treatment for HER2 positive metastatic breast cancer after Trastuzumab, Pertuzumab? All of us would do TDM1 based on whatever data is available. Excellent. Would the presence of brain metastasis alter the choice? Would we jump to doing Capecitabine, Lapatinib if somebody had brain metastasis and not do TDM1? Does anybody have a view on that? You would treat locally and get on to TDM1. Excellent. With the data that I will show, and I'm sure most of you are aware about Tucatinib, if somebody, Ullas will immediately put his hand up, I know, because he is used to Lorlatinib and Osimertinib, which have, 90% CNS activity. Thank you. So, Ullas, what is the best hazard ratio that we have ever seen in oncology, Ullas? 0.12. No, wrong. Keep thinking. See, I've got you on the wrong foot in lung cancer once. Yeah.
At least we got an hint, it is less than 0.12.
It is 0.07. Keep checking where it is. Okay, right. Very good. Let's move on. There you got it. Perfect. You get your lunch. Okay, let's go on. Okay, so with Tucatinib, let's say Tucatinib is again 25 rupees or something like that, just for discussion's sake. With the available data, 47% is the response, okay? Complete response is 5%, nowhere close to Kumar and Ullas, right? As bad as me. Would you be willing to forego local treatment to the central nervous system, radiation, surgery, or one of those? And then in a patient who is asymptomatic or minimally symptomatic, typically the situation in lung cancer where you would skip local therapy, and no, Dr. Raja has already answered no at this point in time with 47%. Would we differ? You would? Okay, of the 5 in the panel, how many of you would defer local therapy and get on to Tucatinib?
Asymptomatic brain mets, yes.
Asymptomatic, yes. All of you, 47% response rate. Very good. That's nice to hear. Okay, so let's take this case quickly. It looks very too long, but I'll shorten it down there. De novo metastatic breast cancer, bone and lung metastasis, Trastuzumab, Pertuzumab, Docetaxel, Zoledronate. Excellent response, like most patients get on this combination. After 14 months of maintenance, solitary parietal lobe met. Systemic was stable. She had surgery followed by radiotherapy, SBRT to that cavity. And then after 3 months of maintenance, Trastuzumab, Pertuzumab, an MRI of the brain showed post-surgery radiation changes and 3 new small asymptomatic brain lesions. Systemic evaluation also showed an increase in the lung and bone metastasis. She's asymptomatic. So the question is, should we do SBRT? Should we just jump to Tucatinib, Capecitabine, Trastuzumab? Remember, this lady has been on Trastuzumab, Pertuzumab maintenance for nearly 2 years. So would we do Capecitabine, Trastuzumab continue, and Tucatinib? Or would you want to do radiotherapy to the brain and put this lady on TDX? Amol.
If the patient is asymptomatic, I will keep the SBRT for the later part. If she
Okay,
becomes
so you would do Tucatinib,
Yes,
even though
yes,
your
yes,
Trastuzumab has been on for quite some
Yes,
time,
yes,
you would still
systemic therapy.
continue. Okay, so this is a gray area because all these patients were off Trastuzumab when they came on to the HER2 climb study because they had taken TDM1, 100% had taken TDM1. So they had a break. So our patient didn't have a break and that's why I asked you that question. Okay, fine. So you will take Tucatinib. Anybody who will say I'll do SBRT and 2 TDX? Why?
Like you said, the important point was they have progressed on Trastuzumab plus Fertilizer.
So you're not happy to continue Trastuzumab and add Tucatinib?
And dual anti-HER2 already there. And TDX is a different mechanism of action and it has shown very good result. And almost I think 40% of patients on Destiny 03 also had CNS mets.
20% had controlled CNS
Controlled
disease.
CNS
Correct.
disease. So that's why you said give SBRT, control, and then put on TDX.
So you are happy to do that. Anybody would agree with Amish?
What is controlled and what is
Yeah.
uncontrolled?
Okay,
Patient
I'll
very
tell you
asymptomatic.
what it is. I'll tell you what. Don't pounce on him. Poor guy. Right? He's the organizer. You guys won't get your return ticket, please. Okay. So, controlled means patient is asymptomatic or minimally symptomatic, or the other set of patients who went into this study were similar, but they didn't have the opportunity of getting onto any more local therapies for the CNS. They had whole brain radiotherapy, they had surgery, they had SBRT any number of times. So half of patients who went into the HER2 climb either did not need any local therapy, at least based on the investigator's discretion, because they were asymptomatic, or they didn't have the option of any more local therapies to the brain metastasis. So that's what is the meaning of what Amish is saying, right? Okay, let's discuss this, Kaplan.
Just question
Yeah,
is
please.
whether a new lesion coming up,
Yes.
is it not a sign of losing control?
Correct. So it is a sign of losing control, and that's why I asked you, would you want to hit the brain and then do TDX, or you want to continue? That's exactly the reason for my question. Very good. We have only 9 minutes to go. Let's rush. Amol, any complaints with this curve? Unhappiness?
No.
No.
Seems to be reasonable.
Early separation, wide, right?
Metastatic setting, it's
Metastatic setting you think is excellent. Excellent. Very good. So Amol, I want you to interpret that p-value for me. 7.8 into 10 to the power of minus 22.
that is exactly why I have no complaints about it.
Excellent. For once, you're happy with something that did not give you an overall survival benefit.
Well, in metastatic setting, PFS benefit, we are happy.
You're happy? I'm happy.
Metastatic, yes.
Excellent. All of us are happy. Excellent. Very good. So the reason why I asked you that question is because the difference seems to be quite significant and is of great value to our patients. And TDM1 seems to be a little underperforming, 6.8 months compared to the 9 months that you got on the earlier studies. But this is a set of patients who are much more pre-treated compared to what went on the Cleopatra, went on to the Emilia and Teresa and all those studies. So that's it. So median PFS not reached versus 6.8, double the number of patients not progressed at the end of 1 year. So I think it's a phenomenally good result. But I think for me, so this is showing you the response rates for patients who went on Trastuzumab Deruxtecan. Nearly 96.6% had some benefit. That means they didn't progress. Complete response rates of 16.1%. So all of these pointing in the direction that this is really a good drug and one should not misusing it at some point in time, whether second or third line is a different issue altogether. The overall survival benefit, that P is actually not significant because the alpha was shared, and so that's not yet a statistically significant overall survival benefit. But I have a small problem here. Now, if you look at the number of patients who went on to have second line therapy, it's a small 29% on the TDX arm compared to 62.4% on the TDM1 arm. Ritu, is that a concern? It's not a concern.
Actually, for a third line setting.
This is second line. So only 1/3 went on to have next line therapy, while in the Destiny 01, the median number of lines for TDX was 5, and the range was anywhere between 3 to 17 lines of therapy. So sometimes these guys, they go on and on and on and on and on. So here you got somebody 70% stuck after the second line. So that is a concern for me. We don't know why, but at least for me, it is a concern. I don't know why.
The previous this thing you have shown that, the PFS 78% at 1 year. So they have to relapse to go on to the second.
No, this is patients who went off the therapy for whatever reason it might be. So
We do not know the disease
I looked
biology.
at that. You're absolutely right. So this is the percentage who progressed, right?
We don't know what it does to the disease
We
biology.
don't know, but this is a concern that has not been addressed most of the time, and 12% discontinuation, and only 11% of the TDM1 patients ended up taking TDX. So very, very likely that you will end up showing an overall survival benefit very soon, because hardly anybody from the TDM1 ended up taking the therapy, and also the fact that very few patients crossed over. We've got only 5 minutes to go, so I've just summarized HER2 CLIMB and DESTINY on these tables.
What about the toxicity part of the TDX one? Are we comfortable with the pneumonitis and?
Correct. So again, since you asked that question, I'm sorry, that's a visual, irritation for all of you. I had that slide, but I took it off. So in the DESTINY 01 Amol, the incidence of grade 3, grade 4 interstitial pneumonitis was around 12%. But it is less than 1% after they put in guidelines as to how to manage and so on and so forth. So I think it's like many of our, the so-called TKIs, wherein when you start using these drugs, you see a lot of toxicity. But when you put in some guideline to monitor and manage these, it looks like you can bring down the incidence of these. It was certainly much better.
What I wanted to ask is that, do you think that in our population, our female patients who may not be as physically strong as the Western ones, the toxicity will be more?
It potentially could be, because even on that, if you look at the Asian subset, there seems to be slightly increased toxicity in the Asian subset compared to the Caucasian subset of patients. So you are absolutely correct. And the other point I want to make in all these studies is that about 60% of patients are performance status 0. In patients with CNS disease on the HER2 CLIMB, I'm sorry again for straining your eyes, 45% of patients with brain metastasis were PS0. Okay, so not typically, at least not typically the kind of patients that I would see, unless you're doing surveillance for the CNS and then picking up these diseases early. And one of the reasons why you're seeing such phenomenally good results is also because these are patients who probably don't go in with tons of disease like our patients when they get onto these studies, is my feeling. Again, I leave it to Dr. Sudeep to, tell us what his thoughts are. So the point is that all of us are happy to get on to Tucatinib if your patient does not immediately need any intervention to the brain. So keeping that in mind, would you agree with this algorithm? This is not mine. It was, it's a slide that I've taken out of Dr. Shanu Modi's talk from ESMO. So this says that you start with Trastuzumab, Pertuzumab. I think all of us agree with that. 35% of patients still are alive at the end of 8 years. That's really good data. And then you get on to Trastuzumab, Deruxtecan. But if you have active CNS disease, one of the options that you probably should look at exercising is Tucatinib, Trastuzumab, and Capecitabine. Do all of us agree with that? Or do you would say that TDX looks so very good, so if there is a possibility of doing SBRT, do TDX, and then get on to Tucatinib? What would you do? Because for me, that's the big question.
I think, sir, at this point of time, I'd be very happy to follow this algorithm.
You will be happy to follow Dr. Shanu Modi. Amol?
Yes.
Tucatinib, and then you will do third line TDX. Very good. Prabhat?
Agree.
All of you agree? Yes, Amish?
I have to slightly disagree.
2 minutes, 35 seconds.
Yeah. So Tucatinib data is in the third line.
Yes.
We are extrapolating in the second line, which is fair enough, not wrong, but we are just just a word of caution because we do not have the direct
Point
data.
well taken, and that's exactly why I said you've been on Trastuzumab for so long. Though there is data for continuation of Trastuzumab beyond progression, when there is another drug that's showing such excellent activity, I am very tempted to do what you're actually suggesting, do SBRT, which is not very toxic these days with the good equipment that our people have and ways and means of doing it, and then put them on TDX and keep, give a break. Putting back the Trastuzumab later, at least, for me sounds better reason than jumping onto Tucatinib, Capecitabine early. But I think I leave it to the wisdom of, people who are managing their patients rather than say that that's the best way to do. But that's the way I would sequence these drugs, because the difference looks phenomenally different, at least when you cross compare. But as you rightly said, Tucatinib trial took a set of patients that had poorer prognosis. So obviously you don't expect the numbers to be as good as what you got with Trastuzumab, Deruxtecan. But then, Amol, that probably is your favorite.
He is spending dollars, I think.
Whatever the currency might be. What I am trying to say is that
rupee is getting worse against dollar.
Correct. So it is also reflecting what it is. Maybe you should get some cryptocurrency, even that is going down. I know I saw your post.
90%.
I saw your post on the group. I'm just phenomenally impressed at the wide range of things about which you have knowledge. Kudos to you. But I think at the end of the day, I use this slide very frequently when I'm, talking. At least, rarely some people call me to talk about statistics. Dr. Sudeep, I'm not talking about it anymore. I've stopped after today, right? So this is about randomized controlled trials and patient-centric care. Okay, RCT is really a paradox. It's actually taking data from the homogeneous to heterogeneous. It's the best way to assess if an intervention works or not, but arguably the worst way to assess who will benefit from it. Many times when patients sit in front of us and I say, there's a 50% chance of response, the next question will be, will I respond or not? And I can never give you that answer. None of us can, but we kind of split numbers over the p-values and the, and that's why I think it's very, very important to understand, that these are, things that will give you a general perspective and feeling of what interventions are and whether they are good, bad, ugly, absolutely useless, useful, relative, and so on and so forth. Ultimately, you have to sit with your patient, discuss, and then decide which is probably the best way to practice medicine, and that's why they call it an art as much or more than what it is a science. Thank you so much, Amish. I really enjoyed this outing, right? After 3 years, it's like as if you've been left out of a, I think you can obviously see.
I liked your terminology of evidence-based ignorance.
Correct,
because so far we have been hammered for evidence-based medicine, but that is a very important.
So the fact that you had this panel discussion,
we
which
can
is
have
because we are ignorant about so many of these things.
But we should be, humble enough to admit that we have evidence-based ignorance.
Thank you so much.
So thank you, Amish, once again for inviting me for the expert comments. I will begin with Senthil's last slide, where he talked about RCT being the worst way to extrapolate. And what came to my mind was a quip or a quote about democracy. It's the worst way of governance except every other that we know about. So, when I was listening to the panel discussion, I was very happy that I declined Amish's persuasion for me to join the panel discussion yesterday, because as I'm growing older and that photograph is quite deceptive, as I'm growing older, my ability to retain and recall information is actually going down. And so all that sticks to my mind is old concepts that change very little or don't change at all. So that's what I'm saying. That talk was about concepts that have not changed in 25 years. This is about information. So I think, one of the most important comments or questions was by Dr. Vashisht Manyar, when he asked that, what should I tell my patient if he asks me, do I have a lower chance of having relapse or death? And I think the way I would answer that question is that yes, you will have a lower chance. And if I treated 100 patients with this new medicine, in four of them, relapse or death would be prevented by giving the new medication. And I do think, Senthil, that 37% is a little bit deceptive there, or 30% or whatever. So the way I talk to my patients is, if there were 100 patients like you, and if I gave this drug to all of them, I would prevent the event from happening in 4 or 5 of them compared to not giving the treatment to all 100. I think that's a better way of explaining to patients. The other thing was about the P for interaction, and I think Amol and Senthil had that discussion about, because the P for interaction for using adjuvant PARP inhibitor after prior platinum was not significant. I think Senthil was absolutely right that we must look at the P for interaction. But I just want to add a small caveat that interaction analysis actually require more data. So they are often underpowered. So the fact that an interaction P was not significant doesn't mean that it actually doesn't exist. It could still exist, provided, if the point estimates are far apart. But in this instance, the safest way to think about this is not to consider that. And I agree with Senthil there. And I was looking at the data when Ulas, you asked about the proportion of patients with strong ER positivity, and actually I did not find any good data, except that I saw that in BRCA1 positive patients, about 70%, about 25 to 30% are ER and or PR positive, and in BRCA2 that is about 65 to 70%. But the strength of the ER expression was not stated in 2-3 papers that I quickly looked up. I just wanted to suggest that it has been shown that ER positivity is actually a worse prognostic factor in young or in very young women, unlike our common conception that ER positivity means a better prognosis. So, we are right to treat these patients with somewhat aggressive intent. And the last comment that I want to make about is the 10 to the power minus 23 in the p-value. So that actually, and Amol said that I'm delighted with that. So that just means that we are very, 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 very sure that that result is not merely by chance. The main point of satisfaction is the distance between the two curves, not necessarily that p-value. So I think all the other points were well made. I don't think that I have anything else to add. There are a variety of conundrums, and as Dr. Advani said earlier today, that we have to think of the holistic picture. Sometimes all of us were talking about SBRT. I have seen many patients with SBRT get radio necrosis not tomorrow or day after, but after 1.5 or 2 years. And I think Dr. Advani, I saw him smiling. I think common sense is still the best guide to treat patient, and one can get thoroughly confused after all the data that one listens to. So thank you.